All right. Hi, everybody. I have the pleasure to introduce that over the next couple of grand rounds, we're going to have our fellows present. I always find this a nice reminder that we actually do have they're in training, but they're also experts in their own right. So it's our chance to learn from our fellows and remind ourselves just the talent that we have in our program. This week, next week is going to be Dr. Mackenzie Garcia, who's going to talk about examining racial health disparities among older adults and dementia and beyond. The other announcement is that our journal club will be on April 9th, 2026. Jean Otero Medina and Madison Turner are presenting. The logistics for today, following today's grand rounds, you'll receive an email with a link to the recording. We'll get an email also for online evaluation. Your feedback's important for our speakers, and please submit questions in the chat. Without further ado, I'm happy to present Dr. Leigh Dairaghi. She's presenting on the state of the geriatrics workforce and clinical training, challenges, gaps, and opportunities. She's currently a geriatrics fellow. She's interested in primary care and medical education, and she received her MD at Rush Medical College in Chicago and then moved to Colorado for residency training in the internal medicine primary care track. And she is very excited. She'll be joining the geriatrics department here at UCH next year upon completion of her fellowship. Great.
All right. Hi, everyone. So I'm going to talk a little bit about the state of the geriatrics workforce and education and clinical training in geriatrics. I would say I'm by no means an expert in this, but it was fun to kind of look through and see what kind of the stats are. Overall, pretty bleak, but interesting to go through. And hopefully this is not surprising to any of you, but something hopefully that you will learn and be able to take away from this. So hopefully not a surprise, our population is aging. These are numbers from the US Census Bureau data kind of over the years. And you can see that in 2000, the US population reached 35 million. And in 2020, it went up to almost 56 million. It was 55.8 million based on the 2020 census data. So it's been steadily going up for a long period of time. And then recently it's kind of had some bigger bumps. In the far right side, that's the population data kind of in 2010 and 2020 by sex and age. The 2010 data is the one that's like the white bars with the bolded outline, and 2020 is kind of overlaid on top of it. It's the blue, like shaded area. And you can see that kind of above that 65 mark, that number in the blue shaded is expanding outward. So we're getting more and more older adults over the age of 65. The dark blue that's highlighted, that's the baby boomer group. You can see at this point in 2020, they're straddling that 65 age mark. And by 2030, all living baby boomers will be over the age of 65. So we've been colloquially referred to the silver tsunami that's growing, and we're getting more and more older adults that are coming into our population. So yeah, in 2020, it was 16%, almost 17% of our US population is over the age of 65, and that's expected to just continue to increase. These are projections, so the same kind of graph, and then the two on the far right in the teal are projections of what our numbers are going to look like for older adults in 2040 and 2060. And so by 2040, with our aging population expected to go up hugely to 80 million, and by 2060, almost 95 million older adults over the age of 65. And this is probably from like numerous reasons that are contributing to it. Baby boomers being like a big piece as they're getting older. That's a big group of our population that is aging, that will age into this cohort. And then kind of just in general, we've increased longevity. Let's see if I can get this. Oops. I can't see all of these. That's okay. Oh. So increased longevity, the US life expectancy currently is about 79 years, a little bit longer for women than men. And it's been relatively similar for a long time. In 2000, it was 77. So we haven't had big increases. We had a little bit of a drop with COVID, and then it's kind of rebounded to kind of the pre-pandemic levels again in 1950, our like average life expectancy was 68 and it was 50 in the 1900s. So it has increased, and recently it's been about the same, increasing just a little bit still. But there is reduced mortality rates for a lot of things. Our procedures have gotten better. We've gotten better at managing a lot of things. And so people are dying less from other like complications and living longer. And then another big piece is reduced poverty level overall for older adults. In like 1966, the poverty level for older adults over the age of 65 was nearly 30%. And currently it's down to 10%. So that has probably hugely impacted our life expectancy and aging population, though there is still large racial disparities in those numbers. So kind of as you can see, like the growth of our older adult population is growing quickly, and the growth of the geriatric workforce to care for these older adults is not keeping pace. And so we have a lot of predictions that we have a lot of older adults that are not going to get the geriatric care that they should. All right. A couple other trends that I just thought were interesting to include, because it will also impact care going forward or potentially impact care, is that more and more older adults are living alone. So rates of divorce are higher. So the number of divorced women aged over 65 increased from 3% in 1980 to 15% in 2023. And for men, it increased from 4% to 12%. In 2023, looking at women alone, 20% of women that were the age of 65 to 75 lived alone, almost 40% of 75 to 85, and then almost 50% of women over the age of 85 are living alone. So more and more older adults are living alone, which you can imagine will impact the type of care they're receiving and the amount of care that's necessary. And then kind of going along with that, with an older population, as the population is older, that's more and more individuals, unless we have some big change in our care, they're going to be living with dementia. And so the Alzheimer's Association, according to them, we currently have 6 million adults who are living with Alzheimer's disease specifically, and that number can increase to almost 14 million by 2060 with these aging numbers. So this isn't new. Geriatrics and this problem has been in the news for a long time. And these are just some snapshots of like recent headlines that I found on Google to include. But this has been kind of like well-versed. It's in the news. People mostly know about it. But it's also not newly in the news. The Institute of Medicine, which is now the National Academy of Medicine, drew attention to the issue back in 1978. They published this. They were like, our population is aging and the care workforce to care for these individuals is not keeping pace. They published that again in 1987 and then again in 2008, where they had an in-depth analysis of the future demand and recruitment need challenges around the geriatric healthcare workforce. And yet, we haven't made huge strides in this area, and it's still a problem that we are currently facing and foreseeing continuing to get worse. So AGS published this state of the geriatric workforce. This was roughly in 2018 when they came out with this data. And so at that point, there's about 49 million adults over the age of 65, and there were 7,000 certified geriatricians. Their estimates for the current number of full-time practicing geriatricians were about 3,600. And so this is all based on data that they said about 30% of adults over the age of 65 would need or benefit from geriatric care, which is a lower estimate, but that's kind of what they were saying. And then they were saying this is also based on each full-time geriatrician having a panel of up to 700 patients. So you can see this could even be like probably a lower estimate based on those numbers. But they were saying based on the current supply and demand in 2023 and 2028 or 2018, when they're looking at all these numbers, the supply was not meeting demand at present or predicted in the future, and it seemed to span across like all areas of the country. And so they were kind of calling for, we needed a 45% increase in the number of geriatricians that were practicing. So we needed to hugely increase these numbers. They were anticipating by 2025, which we have now surpassed, but 33,000 geriatricians was the need that they were anticipating, which we did not even get close to that. They then came up in 2022, they published another of these. Now we're at 52 million older adults from 49. The number of certified geriatricians has largely not changed, 71,000 from 69,000. The full-time estimated practicing geriatrician was 8,000. I'm not really sure why that changed, if they're like changing their estimate, or if they're like counting people who maybe don't have certification that are practicing, but so that's a little bit different. And then they broke it down a little bit differently here versus metro and non-metro. And you can see that while this discrepancy is prevalent everywhere, it's most notable in like rural areas rather than the metro areas. And so they were saying by 2030, in this point, we need almost 12,000 geriatricians, which should be a 50% increase. And a huge change. So looking at the geriatrics training, they posted a couple numbers for like the number of fellowships of family med, internal medicine residents who are entering fellowship. And they said overall they've been about the same. These are numbers from 2016 to 2021, and you can see it's roughly 250, 260 kind of across the board every year, not changing, not going down hugely, but also not growing, especially to meet that demand that people were anticipating needing. So they're saying we need more. Looking at the number of geriatricians that are currently practicing, the numbers are a little bit hard to assess. So looking specifically at board certified geriatricians in 2015 to 2023, this is the graph on the top. The blue bars, the blue part of the bar are internal medicine board certified, and the orange are family medicine board certified. And between these years, you can see, again, similar to the fellowship numbers, it's overall about the same. So even though we've had this call for more geriatricians, we're asking for more, the numbers haven't really changed. Kind of a complication of this is that only 62% of fellowship trained geriatricians who tend to keep their certification. So between 1999 and 2009, only 62% maintained those certifications, which is the lowest rate of all subspecialists in internal medicine. Kind of just for comparison, like over 80% of other subspecialists tend to maintain their certification in their field. And the reasons for this, there's many, but the biggest proposed reasons for them are costs of maintaining it, the time burden that's associated with it, and the low reimbursement for doing so. Looking at the new subspecialty certificates on the bottom on the graph. So this is from kind of 2015 through 2024, the number of new certifications that were enrolled. They broke it down by family medicine, internal medicine. Family medicine, you can see at the top. The numbers are variable, but overall it's about the same. And then internal medicine, the geriatrics line is the bottom line. And so each year it's kind of like 140, one as high as 200, coming back down. So there's a little bit of variability, but overall there's not a huge change in those numbers of new certifications being given out for geriatrics. And I left a few of the other ones just to compare. So like GI is like slowly but steadily been increasing over the years, and then critical care has hugely increased over the years. So that's just to compare a little bit for a couple other ones. And so we can't just rely on geriatricians for this workforce. And I think a lot of the needs of older adults need people beyond what just geriatricians can provide. So what does the rest of our geriatrics workforce look like? Looking at pharmacists, just over 4,000 board certified geriatric pharmacists in the United States as of 2024. And that's less than 1% of the total pharmacist workforce. So a lot of pharmacists, not a lot of geriatric pharmacists. Looking at direct care workers, there were about 5.4 million direct care workers. So that's home care workers, residential care workers, nursing aides. That number isn't going to need to increase with the number of older adults and that number continuing to rise. By 2030, they're anticipating the needing to hire 9.7 million people to fill those jobs. And that's a combination of the growing number of jobs that are needed, as well as the high turnover rate in those jobs. And the highest need is going to be in home care, especially as these older adults are living at home, living independently. And there's a more and more of a desire for these older adults to age in place. And then, as you can imagine, the highest need for these is also in rural areas where we have the lowest amount of direct care workers. Looking at like nursing, APPs, it's estimated there's less than 1% of our registered nurses and 3% of our advanced practice registered nurses are certified in geriatrics. The NP workforce has increased hugely. Between 2010 and 2017, it increased by 109%. We're expecting that number to keep going up. So there's a lot of more people entering the workforce, but as of now, the number of them going into geriatrics still remains really low. Looking at psychologists and geropsychologists, in 2019, there were 660 certified geropsychologists based on NPI tracking, which is less than 1% of all doctoral level licensed psychologists. A lot of numbers I was looking at, they're estimating that even though that number is pretty low, it's probably closer to 4,000 that are practicing in geropsychology, so a lot higher than what is just certified, but that still accounts for less than 4% of practicing geropsychologists, so still very low. And then a couple numbers, we're anticipating a need of 20 to 30,000 by 2030. So similar to geriatricians, that's a huge difference than what we currently have. And then social workers, there's an estimated almost 140,000 geriatric social workers in the US. And so kind of accounting for that, that's a panel of like over 400,000 older per social worker with an anticipated like increasing shortage. So little bleak. It doesn't sound great. It sounds like we're pretty short kind of across the board. Geriatricians have been in the news a lot, but it's everywhere. The whole geriatric workforce is not meeting the demand right now. And kind of a large challenge for all of these, I think, is the numbers are low, but also because the numbers are low, the mentorship and the training levels are low. So in these training programs, very few of them have like geriatric specialists in their respective field for the new trainees to learn from and see and be modeled by. Then there's also like just going off of the direct care workers, that also includes family. As of 2025, there were approximately 63 million Americans that were providing unpaid care to an adult, family member, or friend with a chronic illness or disability. So it's going up. The number of home unpaid family caregivers is increasing, that's a 45% increase since 2015, according to the AARP. So a lot of people are in this field, it's just still somehow not enough. Looking at nursing home staffing, these are from a census, from a survey that was conducted in 2024. Nearly every nursing home in the country is currently hiring. According to this, 99% are currently hiring for jobs. When you look at like the breakdown of what those jobs are, it seems to be across the board: nurses, LPN, nurses, aides. People are hiring for all of them. According to the survey, the different nursing homes stated lack of interest and lack of qualified candidates as being the biggest obstacles to fill those roles and recruiting new staff. 45% of nursing homes are limiting admissions due to the labor shortages. Nearly half of nursing homes are turning away residents looking for care. Over half of nursing homes have a wait list, and then also over half of nursing homes, 56% are have like closed wards or beds because they can't staff them. So they're struggling to fill all of the beds that they have in those facilities. Looking at home health care. So this is one of the pieces that's going to grow, I think, hugely with our aging population. So employment of home health and personal care aides expected to grow by 17% between 2024 and 2034. So currently, there's approximately 4.3 million home health care jobs. This is in 2024, so a little bit ago. And that includes home health, personal care aides. But these jobs have really, really high turnover rates, and it's 64% of a turnover rate. So the need to hire there is pretty much constant just to fill their own current staffing, much less increase based on the increasing needs. And even with these numbers, there's still shortages. 74% of home care providers reported having to like decline clients and turn away based on the worker shortages. And this is probably multifactorial, but the biggest piece seems to be wages and compensations. Like the median annual wage for home health and personal care aides was under 35,000 in 2024, which is less than $17 an hour. So doesn't seem great, but there is some hope. There's a lot of methods that are currently being employed to try to increase this. And so these are a couple of them. There's federal training programs such as GWEP, which I can go into in a little bit more detail in just a moment. There's a number of financial incentives, loan repayments for geriatrics care for like multiple providers in the workforce. There's more and more telehealth options, and more places are starting to utilize telehealth options to expand, especially for rural care and accessing those patients with the highest discrepancy between the need and the care. More and more, we're building some really great interprofessional geriatrics teams. We're relying on those other providers to help kind of compensate and take up some of that care. With the growing APP workforce, that's been a big one that's been tapped into to try to recruit some of those APPs into the geriatric workforce, trying to get more pharmacists, and then essentially trying to expand, and so that we have geriatric providers or geriatric trained providers more and more outside of geriatrics. Geriatrics fellowships, which as we know are not doing great. More and more options to try to play with these and see what we can do to try to make them more incentivizing. And so either having med-geri programs, combined pathways, doing dual fellowship pathways with other fellowships, and then in general, just building better age-friendly systems so that these older adults are getting age-friendly care even in the absence of these specialized geriatricians and geriatric workforce providers. So going into some of these a little bit, the geriatric workforce, or GWEP, was started in 2015. The Health Resources and Services Administration started it with the goal of kind of addressing the shortage in the geriatric workforce. And so it's a federal program that's designed to train health professionals and supportive care workers in dementia-friendly and age-friendly care systems, with the goal that they would then come back and practice in these systems to fill some of that gap. And so a lot of the projects that they funded were developing these partnerships between academic programs and the care delivery systems, so like nursing homes, primary care sites, rural sites, community organizations, to try to build a connection so that the students get exposure and training, and then hopefully they're coming back and then working in those places where they trained. HRSA funded GWEPs to train nearly 1.4 million individuals, including caregivers and staff, between 2022 and 2023. So their reach was high. Unfortunately, the funding has already been cut in 2024. There were severe funding cuts by as much as 34%. They weren't able to fund as many of these programs. Sounds like I think they cut like 19. They added roughly 17 or something. That math doesn't make sense, but they ended up now there's 42 sites that are currently funded across 37 states. So it's still present, but the amount of funding has been severely cut. Looking at geriatrics fellowships, this is Google's rendition of a bleak landscape. It's considered one of the least competitive fellowships of all of the fellowships, which is sad. The fill rates for geriatric fellowships have been about 40 to 50% for many, many years. Over the past 6 to 7 years, it's been pretty stable, has not gone up. 2025, the geriatrics match data came out. The geriatrics fill rate decreased a little bit even further to 39%. Hopefully that's just some fluctuation of the years, but it's hard to tell. And 21% of the spots filled in geriatric, or of the spots were filled by international medical grads. So not even able to fill everyone by the interest that we have by people trained here. Of the 750 internal medicine positions total unfilled in the match, 188 of them were in geriatrics. So 25% of all unfilled internal medicine fellowship positions were geriatrics, which is very, very sad. Meanwhile, in 2025, the overall data showed that of all the applicants who applied to fellowship, 75% of them successfully matched. And that's 2.4% less than the prior year. So overall, the competitiveness of fellowships is increasing, but geriatrics is not keeping pace with that. And just to compare a little bit with some of the other numbers in the 2025 match, cards filled 100% of their positions. Home crit filled 99%. GI, HEMONC, rheumatology also filled 99%. Endocrine 97%, nephrology 66, 90, 61. So we're the lowest by far. And there's a lot of proposed reasons for why people aren't going into geriatrics fellowships. And they're similar kind of across to the other reason people aren't going into geriatrics, but salaries being a big one. Salary in geriatrics is often less than general internists and hospitalists. The high level of student debt is a big concern, kind of going off of that salary, and now it's expected to be even worse with our big, beautiful bill. We limited student funding. So we got rid of the Grad Plus loans, and so we capped student loans at $50,000 a year and $200,000 lifetime for professional degrees. Meanwhile, when you look at the average med student debt from 2025, it was an average of $217,000, and of the people who borrowed money, over 32% borrowed over $250,000. So these people are going to have to look other places for these finances and are even less likely to go into a less lucrative option. Kind of other things that are probably contributing to this. Limited exposure is a big piece. I would say just anecdotally, a lot of people that I came into residency with didn't necessarily know that geriatrics was a field, wasn't something they'd really learned about in med school. Geriatrics has very low perceived prestige, and so if that's the big concern, people are not going into it. And then there's a really high level of patient complexity in geriatrics, which is part of what makes it so great when you compare that to the high levels of burnout for residents. It's not something that sounds appealing. And then there's ageism in medicine, which is not helping anyone. Here. And so talking a little bit about exposure, geriatrics exposure during medical training is low, and we don't have any great data that really standardizes or looks at what geriatric training in medical schools or residencies really looks like. This is a recent study, relatively recent, it's 2022. They did a website review that looked at all 191 accredited US medical schools as of 2020, and they looked for the online visibility of geriatrics. And so they made these like core components, and they said whether or not the medical schools had them, at least based on their online presence. And then they graphed them here. So a couple things to kind of call out. The orange bars is that only 45% had any required clinical training in geriatrics. And then 37% had a non-clinical course requirement related to geriatrics. So at least based on the online visibility of this, the geriatric exposure is really low. This group then kind of based on what they were finding, sorted all of these schools into high, medium, and low online visibility schools for geriatrics. And only 20% of all of these met the criteria for high online visibility. So at least looking at their websites and kind of what their courses and criteria looked like, geriatrics was only well represented in 20%. When we look at exposure data, they then surveyed, this is the same group, I believe, who's been 2025 surveyed medical student deans. So they sent out surveys to all of the accredited US medical schools. Their survey response rate was about 73%. They heard from 140 of the programs. And a lot of the data is on the far right side. So you can see at the top, the dark blue line is kind of what the deans estimated their current level of geriatrics curriculum looked like. Most of them said it was moderately developed, but over 25% said it was only a little bit developed or worse. Interestingly, the desired level doesn't seem to be that high. The 25% of the deans only wanted it to be moderately developed, and only 25% wanted it to be extremely developed, so also questionable. When they look at kind of below that, that graph looks at things that were motivating to change to increase geriatrics training. It was kind of like accrediting geriatrics a body geriatrics requirement was a big piece. Funding, having faculty championing, were all pieces that they recognized as being important and good incentivizers to change this. And interesting themes that came out of this are kind of in that top bit. They generally felt that geriatric topics should be included, which is great. They felt that students already interact with older adults, but they did point out that exposure to older adults does not equate to geriatrics education, which is good and important. They noted trouble finding geriatrics trained faculty, which is probably going back to the shortage of our geriatricians. They said adding geriatrics curricular content was challenging, which also may go back to the shortage of geriatricians. And they said that geriatrics was well suited for integration into the existing program. So there is hope, but it's not currently there. And these are some quotes that they had put in the article that I just thought were interesting, and they're kind of focused on the fact that a lot of these programs used to have geriatrics electives or requirements, and as they revamped the curriculum, a lot of these things got lost. And then one of them pointed out that unlike peds, across the rotations, people get exposure to older adults. And kind of as we know, just exposure to older adults does not equate with the training, but they did mention that that should make it easy to be able to integrate more geriatrics training into the existing curriculum, which I thought was a good point. AGS has created minimum competencies in geriatrics for medical students. This was updated in 2021. This is what it currently says. And they have kind of competencies of what they would want for each of these within the 5 M's. So this exists, and this has existed for a while for medical students or for medical schools to look at. However, there's not like a great way to assess like, are medical schools meeting these? Are med students meeting these when they graduate? They've tried to look at this, and it seems like there aren't any great data that's been done so far. This group just recently, 2025, looked through kind of all of the data. They did a scoping review of validated geriatrics knowledge assessment tools, and they included ones that were included for physicians, medical students, variety of residents, including surgical residents, psychiatry, EM, geriatrics fellows, non-geriatric faculty, that had different geriatric assessment tools. The tools seemed to be a variety. Most of them were a pre and post test. A lot of them were multiple choice. They were attitude tests. A few had standardized patients. They found that a lot of these publications were just trying to validate their own teaching tools. And so ultimately they said, we don't know. We have no data, is what they ultimately concluded. Like 36 studies use validated geriatrics knowledge instruments to assess changes in knowledge, usually pre and post some kind of intervention. But there's like no data that really shows things have been changed. Nothing has been consistent. They weren't able to really get anything out of this. And so they essentially concluded that despite the availability of this data of validated geriatric assessment tools, they've not been used in a way that's usable. And so we don't know kind of what our students are learning or prepared for. This was an older one, looking 2023. I feel like there's a lot of studies that I saw that looked at attitudes towards geriatrics or older adults in medical school and a bunch of other training groups. None of them seemed to be all that great. This one, they found of the 27 studies that they looked at, 14 of them showed a positive attitude change after an intervention. 13 of them did not. But when they broke it down by the type of intervention that was done, 11 of those interventions were solely knowledge building content. And of those, only 3 or 27% showed the positive attitude change. 16 of the interventions had some empathy building component. And so whether that was just contact with a healthy older adult and some kind of aging simulation exercise. Those ones had a much bigger positive change. And so 11 or 69% of those showed a positive change. And so kind of not all training and exposure is equal. If there's kind of empathy building, it seems to have a better success. Kind of moving a little to APPs. APP training is complex. It's what I've learned. APPs have been a proposed model to help fill the gap in the geriatrics workforce. And so that's PAs and NPs. And largely this is because their training is shorter and at a lower cost than their physician counterparts. And the APP workforce is growing, and it's grown hugely, and it's expected to continue to do so. However, about 15% of NPs and 0.8% of PAs currently practice in geriatric medicine. And the number has gone up. The NPs, some numbers I was looking at said it tripled since 2010, so that's bigger. The 0.8%, that's 2018 data, so I didn't see anything more recent than that. And kind of why those numbers are so low, it seems to be the same as what we've been talking about. The exposure is low. Training might not be quite as adequate as we want it to be. There's a lot of kind of survey data that looks at NPs and PAs graduating from their programs, and they don't feel prepared to care for older adults and the complexity of older adults. And then a lot of them expressed interest or desire, if they were to do so, to have additional training, but those training options are low. In 2014, they did a study of 2 Colorado NP programs here and in Colorado Springs, and they interviewed 9 of the NPs who are graduating from their program to try to talk about how to increase geriatrics training in the programs. And the big themes that came out of that were that they did not feel prepared to care for older adults because of the complexity. And they felt that the training that they got, while it was good and they could not come up with great ideas of how to change it, felt like the on-the-ground job was so different that they didn't feel appropriately prepared. And a couple of them had expressed interest in further geriatric training, if available. There was another study where they looked at PA students in 5 different Pennsylvania programs. They gave them a 10-question survey about their programs. And based on the responses, at least at this point, the required geriatric coursework was only present in 62% of programs, and required geriatric clinical exposure was only present in 54. So geriatrics exposure and training seems to be low and not standardized. This one, so APP Geriatrics Fellowships seem to be newer and seem to be growing. I could not get a great sense of how many exist at this point. The VA has some, and this was one that was started at the VA in 2022. And these are survey data based on their cohort, their inaugural cohort, which is an N of 2. So not a lot of people, but they did assessments kind of throughout, like at the beginning, 6 months in, 12 months in, both faculty rated NP competence and self-reported confidence in their practice. And both of them went up significantly, both their competence and their confidence in caring for older adults. And their comments about this is also by doing this, we can increase retention. So they trained these people, and both of these individuals stayed on at the VA kind of after their training within the field of geriatrics. Pharmacy training, I just included this one about it, but overall it seems to be pretty similar. The amount of geriatrics exposure and training in pharmacy schools also seems to be not standardized and super variable. This was a survey similarly to the med school one sent to pharmacy school deans. They sent it to 148. They only got 43 responses, so this isn't a great response rate. And kind of highlighted only 35% essentially had required geriatrics courses. Only 63% even had elective geriatrics courses. Kind of below that, the number of advanced pharmacy practice experiences, only 14% had required ones in geriatrics, only 78 had electives. 44% of the deans felt that their curriculum was insufficient to teach geriatrics, and 33% lacked confidence that the profession of pharmacy was adequately prepared for the aging population. So the trend seems to be very similar to what we've been seeing. Um, Things have changed. I would say this is more of an anecdotal piece, but a lot of med schools have had some large revamp in their curriculum in the past like 10-ish years and various methods. Happened here at Colorado. They revamped it. Um, and so this is the current curriculum, the Trek curriculum. I have a breakdown. It's very confusing for everyone who doesn't know it very well, and I still get confused. So this is a little bit of the outline. But when they revamped this, kind of at CU, the mandatory geriatrics content hours were cut by 33% compared to 2018. So here also the amount of geriatrics training has been cut and is going down. Um, we're currently doing a project to try to increase some of this geriatrics training in the med student curriculum. And so this is just a look at their curriculum. So this is like their online system. And when you type in various keywords, you can see courses that pop up that meet the requirement. So when I typed in geriatrics across the entire 4-year curriculum, the big red bubble and the orange bubble are the disciplines by Trek year. So those are 2 different years, and you can see only 2 years have any courses that kind of contain the keywords or associations with geriatrics. And then the other ones are the disciplines, so kind of the breakdown and kind of where those lie. So at least based on this rough search, it doesn't look great. There's not much. Kind of looking specifically at the 1st-year curriculum, older adult appeared in 1 session within the lifestyle reproductive block. Death, dying, matters most, mobility all had like 1 session associated with it. Oftentimes they were the same session. Dementia came up in 2 different sessions in the nervous system, mind and behavior curriculum. Advanced care planning showed up in 4 different sessions. No sessions came up with the terms 5Ms, frailty, or multi-complexity. And then kind of going through of the 46 sessions that we deemed relevant or potentially relevant to geriatrics based on the list of priorities and kind of based off of the 5M competencies, only 13% or 28% of those, 13 or 28% of those directly reference geriatric related terms in their descriptions. So not great, but a lot of potential to add geriatrics to the curriculum. So just to end, overall, it might look bleak, but there's a lot of hope. These are just a kind of a list of all of the current geriatrics exposures or things that are happening here. So there's an integrated kind of stealth geriatrics curriculum that's being added to the 1st year, ways to add geriatrics content. That's going to come into play next year with the new M1s. There's integration into team-based learning cases in the 2nd-year LIC, which is also going to start next year, this summer. There's pilot integration of formal geriatrics clinical experience into select LIC sites. That's going to come the following year. There's a current 4th-year med student elective run by Dr. Garfield, which is supposedly very popular. There's a proposed 4-year geriatric concentration, which would be 4 years of longitudinal experience. We're adding increased didactics for the IM residents. There's now like a geriatrics intern lecture and the new master clinician series. There's GEM exposure at the state vet's home with the subacute rehab patients for all internal medicine categorical and med peds residents, and we're at proposed expansion to the hospitalist track. Dr. Uncle and Dr. Clark have formalized the nursing home curriculum for the family med residents. There's the new GERI elective for the family residents. There's some proposed formalized opportunities for the Colorado State family med and IM. And then there's a formalized long-term care curriculum for the PAL Care Fellows alongside us at the nursing home. So there's more and more geriatrics that is being taught and being exposed to people, but I think we have a long way to go to get there. So that is it. Thank you all.
Right. Thank you so much, Dr. Dairaghi. I'll open the floor for questions.
Thank you for this is a lot of data to go through, so I certainly appreciate that. That wasn't trivial. I am not a geriatrician, so like I just want to set the context for the question. So the question's somewhat integrative. I remember hearing when geriatricians and Carrie were reflecting on geriatric fellowship this year and what might inform if someone comes here for fellowship. It had a lot to do with geographical routes that were set based off they didn't want to move. And so appreciating that there is this imbalance of increasing number of older adults coupled with this lack of consistent increase of geriatricians, could one approach potentially to solve this seemingly daunting issue be targeting asking the question, where are the greatest number of older adults geographically? And can we try to build the fellowship programs more from a geographical perspective to target where those older adults are living rather than it being this like sweeping suggestion?
Yeah, I think geography is tricky. And I'm like, no, by no means an expert here. Jada, if you want to jump in at any point, you can. Um, but I think it's also where people want to live. And so when people are picking fellowships based on where they want to live, I think it makes it variable. And I think that's what a lot of the fluctuations, like here we had 1 year we had 4 fellows, 1 year we had no fellows. And I think that's largely based on where people are and kind of if you have people interested in geriatrics at your institution, they're more likely to stay or go back home than they are to move somewhere new. And so I think that's a big piece. But with the rural piece, I think a lot of it is that people don't want to move. A lot of physicians don't want to move rural. And so I think that's the limitation. And so I don't know. I think that's hard. I think we need to increase care and I think recruit people who want to work in those environments, I think will be the best because they can then train and then move there. I don't know if moving training to rural places would be as exciting for people.
I thought you did a really great job. I'll take the opportunity to ask a question. I thought you did a really great job, really spelling out how, on the one side, you have this growing population that we're supposed to be serving. That's a version of demand, and how that's just not translating or percolating all the way through to the profession, to the training of individuals, to interest among students. I mean, you went through it probably most recently. Can you tell us a little bit more about, again, what you found seems to pique your interest, but also potentially piqued your colleagues' interests in geriatrics?
Yeah, and I think people go into it for a lot of different reasons. I can say I did med school at Rush in Chicago, and the geriatrics exposure wasn't great. I think I don't remember specifically, but I think we had like a course on like older adults, and that was kind of like the class that we had. I don't think I realized geriatrics was really a thing until my mom, who's not in medicine, like pointed it out to me. And then I kind of sought out those experiences, and then I really liked it. But there was no required clinical geriatrics experience for me. And I think a lot of people had similar experiences to that. And so I think the more you can see it, the more you can even consider it. And right now, I think we're not quite there. But I think there is more pieces like people aren't going into primary care, like people don't want to do extra training right now. I think kind of just the landscape is a little bit rough.
We have one question online from Dr. Julia Bellantoni. Knowing our workforce isn't keeping up with demand and it's unlikely to ever fully meet the demand, do you think geriatric medicine needs to pivot, become more of a subspecialty consultative field for both patients and healthcare providers rather than primary care providers for older adults? I've seen geriatric medicine practice very differently across the country. Some health systems more PCP geriatricians and some purely consultative. Curious to know of your thoughts.
Yeah, I think it's changed. And I think you guys all probably have a better sense of this than I do. But even interviewing for fellowships last year was really interesting about how people are approaching geriatrics and what they want to do. I feel like it has moved much more to a consultative service. And I think that allows geriatricians to at least provide care for more and more older adults while not being the primary person for them. And so I think it's going to change a lot. And I think it's interesting to see how it does. But yeah, I think it's the field is changing for sure.
Thank you. This was a great overview. Question about the like direct tracks from like IM combo fellowships. Do those exist for Jerry? Do they have like rates that are better than the standard match? Like, is that a viable potential? Can we like capture people when they're interviewing for med school? Do you think that's like a potential?
Yeah.
I don't really know much about that other than some people we went to residency with that did the like IM to onc direct.
Yeah, and Jana, you can jump in here too. I think the ones that I've seen, they do exist. All the ones I've seen though essentially don't like a lot of the benefit of the combined pathways is shortening training, and the ones that I've seen at least for like the med Geri pathways haven't shortened training. So there's not a lot of benefit to doing that at the moment.
We did have our first applicant for the combined physician scientist training program in geriatrics this year, to be determined on match day if we will have that individual in 4 years or so. But certainly that was the first in the history of CU's PSTP program. So that there's that. And then with the med Geri programs, exactly as Leigh said, there are IM Geri combined training, residency, and fellowship programs, still 4 years. And really the advantage there is earlier integration of geriatric exposure and then additional sort of clinical exploration and research time on the back end. It doesn't shorten training, and you're taking people who've already early self-identified as geriatric interested. So I don't get the sense that those are really moving the needle on the overall numbers. We're taking people who were already going to end up at that endpoint and just keeping them in the same healthcare system is really what those programs do. So it's unfortunate.
So with such limited exposure to geriatrics, is there, have there been like surveys or data about trainees' experience when they have exposure and like what they like to see, like what things make them want to do geriatrics, what things they don't like that make them not want to do geriatrics? You know, if we have such a limited window to convince people to go into geriatrics, are there things we should focus on when we're working with learners?
Yeah, there are some, and there's nothing that's recent, and the ones that I could find were old and not that applicable anymore. So they're really it's something to be explored, to kind of survey people a little bit more about what's going on and why people are going into geriatrics. In the past, I think it's been kind of like a lack of it being an option. Some of the studies had like geriatric concentration programs in med schools, and so they interviewed those people. And it sounds like they were overall well received. People liked them. Programs found them hard because they were like intensive and expensive, and they needed to have the right faculty members, which they didn't always have to do them. And then they didn't necessarily like result in people going into geriatrics, which I think is fine. I think if more and more people just have geriatrics exposure and training, considering like unless you go into peds, most of our residents are going to treat older adults and could use more training. But yeah, it's definitely a field that has not, we don't have a lot of data there.
I had one more question. Actually, the one group that seemed to grow so much was the nurse practitioner group, right? So what are they doing right? Because if we could get those growth numbers, it seems like we'd be set.
Yeah. I don't know. I mean, NPs, I would have to have someone else speak to this a little bit, but I think the training is shorter, it's less expensive, it feels like a more viable field to go into. So I think more and more people are going into it, and now we just need to get those people to then come into geriatrics.
Just a comment on public perception. I had a friend text me watching The Pit, and apparently they recommended one of the physicians switch to geriatrics because there's lots of spots there, so you can match there, and they were upset. So that's like our public perception in the most popular medical show right now. But my question, it seems like a lot of attending physicians gain interest in geriatrics after they've been practicing. So like being ACE core faculty is probably the most popular faculty spot for our hospitalists here. And I'm wondering, how can we engage those physicians who probably don't want to take a dramatic pay cut to complete a fellowship program, but would probably love the additional training and certification.
I love that you asked that. This actually has come up before. Jana was saying there's a Denver health hospitalist who I think has expressed interest, who similarly became interested in this after being a hospitalist for many years. And it would be really great if we could have some kind of fellowship that wasn't like a full-time fellowship, but like something that's part-time so people continue to work but get the geriatrics experiences. I don't think anything like that exists to this point, but would be really great because I think that is a big group of people who would be interested and would really benefit from the training.
There are two part-time geriatrics fellowship programs in the entire country. One in South Dakota and then one in Pennsylvania. Both seem to be targeted at hospitalists, which is a model that I think works better with a part-time fellowship than primary care, obviously. The program in Pennsylvania only matches people in pairs, and so they cover for each other. But we are in very, very early stages of contemplating something similar here, and kind of doing needs assessment and reaching out to those programs to see really what the demand is. There's not a lot of research on interest in part-time fellowships, so but you're thinking in the right direction, I think.
I was thinking we need Dr. Glaucomflecken to have a geriatrics persona, right? Uh, that's what we need to increase our presence. Thank you very much. Round of applause for Dr. Dairaghi.